already. She's going to talk to us about research trends and data.
All right, thank you very much. So I'm going to just, I think, bring together a lot of the concepts that have been talked about this morning and talk about what I've been seeing, looking at the literature and experiencing with emerging trends and research. As we know, we have some grant support from the SVS Foundation as well as the NIH. Here. All right, so in general, when we're thinking about the things that are happening in the vascular surgery world for limb preservation, I believe it's being addressed at multiple levels. One level is at the society level, the Society for Vascular Surgery, and establishing guidelines and approaches to deal with limb preservation. At another level, it's the multidisciplinary team, and this is my toe and flow artwork, which I'm very proud of. I made it on PowerPoint. But again, it's so important, the anchors, the podiatrist and the vascular surgeon, toe and flow working together. And then finally, this trend of people starting to understand that this is an epidemiologic issue and trying to start encountering the challenges of actually illustrating this issue when you're researching it. So the first thing is the Wi-Fi, the Wi-Fi classification system, and this was created by Dr. Mills and company. And this is one of the things that I see as something that the Society for Vascular Surgery has really been pushing. And the way I kind of view it, it really helps to provide an understanding that this is a comprehensive disease process and that it helps us to understand, to guide the management. So will they benefit from a revascularization or not? So what is the potential benefit there? As well as what the expectation is, which is important when having that discussion with the patient to guide those expectations. And it takes the three major issues: the wound, so the extent of the wound, was there gangrene affecting it or not? The ischemia, so is there arterial disease, particularly looking at toe pressure, but also ankle pressure questions. And then again, is there foot infection? And this is how much cellulitis is surrounding it. And these were built together to build a predictive model to help guide care. If you go to the SVS IPG app on your phones, you can download this, and then you can actually just use the calculator in the palm of your hand when you're seeing the patient. And you can kind of go through everything and say, ulcer, gangrene, ABIs, whatever you have. I just kind of threw some stuff in there. What not looking good for my patient in this example, but you can see down on your right-hand side here, the amputation risk of this patient based on mild infection, but borderline, not great arterial flow. And I think I may have given them gangrene in this example, but the revascularization benefit was also high. So it helps to guide the conversation. This has been researched as a predictive level, and we already saw some articles on this. This is stated to be the first article, and it was presented actually in Canada at British Columbia, I think at the Canadian Vascular meeting. But it showed that on multivariable logistic regression, the Wi-Fi was actually predictive in diabetic ulcers. Prior to that, it wasn't as strong apparently. And what this article found was that stage 4, which is the worst compared to stage 1, had significant differences in the odds of healing and the time to wound healing. So this just shows that this is a good predictive measure. They also looked at the things that had the greatest effect on wound healing. So Wi-Fi stage 4 had one of the worst effects on wound healing. The wound area was very important. The stage 3 was also bad, PAD. And I will tell you from my own research, looking at our state data, the addition of arterial disease to diabetes is really what's driving the amputation issue in our state anyways, and we'll have publications hopefully in the near future that will talk about that. But the PAD is something they found also. In addition, the time from wound onset to assessment, and in their findings they actually found that clopidogrel was actually protective. Now moving on to the multidisciplinary team model. I'm not going to spend too much time on the putting together of a multidisciplinary team because that's been covered earlier today. But again, the importance of the toe and flow as the anchor, the podiatrist and the vascular surgeon, the toe amigo and the flow amigo, as Dr. Armstrong would say. This is important, and then from there you bring in the other parts of the team. And this has been shown, and I believe some of these have been pulled up already by Dr. Neville's lecture, but they have been using just a combination of multidisciplinary care and simple limb preservation strategies to try to prevent amputation with excellent results. And so there's 4 studies here I'm going to briefly cover. But it's really common sense care, and it's the LEAP, the lower extremity amputation prevention model, which was created for leprosy. And it's about people that don't have neuroprotective or sensation in their foot. And just these guidelines of, checking the feet, looking at a high-risk foot, and teaching people how to take care of their feet, and monitoring the foot. And so this was done in several programs. So the first one here is the Pact Program. This is, again, from Veterans Affairs. And they had the ability to combine their medical record where they could identify patients that were high risk. And they looked at people that were high risk with high-risk feet, and they had them in their system. So they actually could track them, and they sent them into a multidisciplinary clinic that monitored their foot according to their protocol, and just used LEAP protocols with that. And they found an 80% reduction in amputation rate based on that. And this is their little protocol here. Hemoglobin A1C, all the important stuff, foot exam, categorize them into a risk category, assess them for footwear, give them education, and establish a management plan. That's it. That's what they were doing. And that was an 80% reduction. The next program was also using, so this is a LEAP program in an African-American population in Louisiana. And this was a low-income population. And again, just using this program led to significant, so this was a 79% risk reduction based on just applying basic principles and multidisciplinary care in that setting. Finally, the staged diabetic foot management system, which was done in a Chippewan American Indian community in Minnesota. And what they did, they actually did it in 2 parts. So in the late 90s, they used the LEAP protocol alone, and then they added a stage diabetes management protocol to it. And these are family medicine physicians. And basically, so they taught LEAP, but then they also gave them this flow sheet of what to do. So abnormal foot, low risk foot, have them come back in a year. High risk foot with an ulcer, have them come back in 2 weeks, if not better, refer. So giving the actual information there, and they found that by doing that, they had a 50% reduction in their amputation rate. So these simple programs that organize care and also add the multidisciplinary care, and just in general, there's a lot of different things in the system talking about the tone flow teams, and there's ranges of 36 to 86% reduction based on the literature. So back to the concept that we started earlier this morning, where you live matters. So amputation is a contextual issue. There are other things happening that we need to understand in order to actually prevent amputations from occurring. And so perhaps, like we said before, if you're dealing with a very rural community where you have poorer health in general, lower socioeconomic status, lower education population, lower access to things, this becomes an issue. Again, access and overall stress load of your patient population. These things matter, and how do we prove that these things matter for amputation? And so that's where our spatial epidemiology comes into play. Now, amputation is interesting, and rural patients are interesting, because when you deal with rural patients, you have to deal with issues of low number counts. And amputation happens to be, even though for us it's the world, it is a rarer disease, right? You're dealing with smaller number counts, which makes it difficult when you're trying to actually do science with it, because you have to start aggregating groups of people to try to get numbers. And that's not good when you're trying to look at a small area. So for example, if you're trying to look in a community that has 1,000 people, and that's one zip code, and then you can't do the math with it, so you have to spread it out, and suddenly you're looking at like a huge swath of geography, and that becomes problematic. And so Bayesian methods, though, have been introduced recently with different types of disease processes that are similar to show us that we can actually get very highly granular pictures when we use these methodologies. And so that's advanced spatial modeling, which is what we're applying to amputation in our group. So this is an example by Grossen et al. It was published in 2018, and this is for suicide trends. And if you look up at the top one, they had to suppress anything that had less than 20 counts because of patient privacy issues. Okay, so that's what America looks like for suicide trends if you just look at this time period here, okay? The other option they can do is they can say, all right, well, we can't do this, we don't have enough numbers, so we aggregate it over a large number of years, so 11 years of data. okay, we're starting to see more of a picture, more colors are starting to show up, but this is over a long time period, which could be a problem when you're looking at trends. Other option is to aggregate groups over counties. So that's in C. And you can see there's the colors there, and again, there's larger swaths of data. It's not giving you very detailed data. Finally, she applies the predictive modeling using Bayesian methods, and all of a sudden, here in D, you have this very highly granular way to look at this issue. And that is something that we do with our amputation data, and that can actually get us to zoom in on small local areas so that we can actually allocate resources in a way that's effective to prevent amputation. So that is one way that we can look at that. The other thing, and I'm going to go through our data, and I just want to give you some basic information. So when you look at the maps, whenever any disease process, you're looking at the maps, they're going to be they may be giving you a heat map. A heat map is literally, it's descriptive data. The hot red picture is not necessarily significantly different than its neighbor. So when you look at a map, it's very tempting because the colors like guide your eye, but they have not applied inferential statistical techniques. And it's important to know that when you're looking at these maps. You can apply things though. You can do cluster analysis and you can have spatial outliers, and then you start to see, oh, this area is very different than its neighbor. Well, what's going on here? That becomes interesting. That's statistically significant. And then you can also apply things like standard deviation. And then on top of it, you can build really cool predictive models where you are controlling for covariance, and that allows you to see something much closer to what's going on. So this is the state of West Virginia. This is what we built using the West Virginia state data. This is our Choropleth map. Okay, so this is looking at amputation levels, and what we show up top is just at the county level. But then what we're showing here, again, different images of scale, looking at scale. And so using the Bayesian methods, we can get a much, much higher granularity down on the bottom here. And you can see a difference where you're looking at amputation rates of 9 per 1,000 to 34 per 1,000 in certain areas, in certain zip codes. The national prevalence is like 2.4 per 1,000. So that means we have an issue, and that's important data to bring to the government when you want to talk about funding. The other thing that we applied to this data, here's a cluster analysis. Now this helps because it wipes out stuff that's not significant. And we got this area here, two areas that really jumped out. Pocahontas County here, it's way in the mountains, and then up here on the border of Maryland. And these are significantly different than the rest of the area. The orange areas are actually much lower than its neighbor. So both of these are areas where that could guide my interventions or guide my questions. And then this is the next step, which is you take with this data, you do more mapping and you look at all of the possible comorbidities that may affect amputation. So we applied all these different things, and we just so you know, this is this descriptive data of how things are not equally distributed. Risk factors are not equally distributed across the state. We applied those risk factors to our model, and now we've built a predictive model where we still have areas. These are lighting up even when we are controlling for risk factors. So again, place. There is something going on. It's contextual. There's something going on here that is leading to higher rates of amputation, even when I control for CAD, diabetes, PAD, PAD plus diabetes, Medicaid, which is socioeconomic markers. All of these things, there's still something going on in these areas, and that's what's guiding where we're going to make our questions and how we're going to guide our interventions. So I don't think we're going to have a ton of time to discuss this stuff, but just talking about barriers to practice change. So it's some things that I just kind of thought of, education and availability of protocols. So actually, us as surgeons and wound care physicians going out and teaching our fellow physicians potentially what we can do. What is the availability of specialists? And so that's something we're mapping, we're looking at. We're actually looking at this information to see if that does significantly affect amputation or not, because we all like to think we're going to make a difference, but it's possible that putting a bunch of vascular surgeons in the middle of nowhere may not make a huge difference. I don't know, we don't have the research. Access to care at all levels. So again, every aspect of care, from the primary care level, prevention level, secondary care, as well as tertiary, getting them to the hospital in time. So really, do your primary care doctors have the time to talk to the patients? In the American system, I don't know how it is with you guys, but we have like 15 minutes to talk to new patients, or for established, 30 for new, and how many can you see in a certain amount of time? This becomes an issue. Overcoming barriers, I have to kind of stick through this, but. So takeaway points, there are strategies at multiple levels being employed by vascular surgeons to reduce amputation risk, and and society guidelines and algorithmic protocols are happening, they're available. Multidisciplinary teams are a big theme, and understanding the issue at a broader societal level is going to be really key for us to make any impact over the long run. And at all levels, coordination and access to care is a key component. And thank you.